What if we've been over-imaging one of the highest risk patient populations in medicine? For years, if a patient with active cancer came to the emergency department with suspected pulmonary embolism, many of us skipped clinical prediction rules altogether and went straight to CT pulmonary angiography. The concern was understandable. Cancer changes everything. D-dimer is frequently elevated. The consequences of missing a pulmonary embolism can be catastrophic. So why take the chance? This week, a major randomized trial asks whether we've been exposing thousands of cancer patients to unnecessary CT scans. We'll also examine a bronchoscopy study that challenges another long-standing habit. Many bronchoscopists instinctively instill cold saline or diluted adrenaline before taking an endobronchial biopsy, hoping to prevent bleeding before it starts. It feels logical, but does it actually work? And finally, instead of discussing another randomized trial, we're going to step back and ask a bigger question. Why do so many ICU survivors leave the hospital alive but never truly recover? We'll explore what modern critical care gets right, what it still gets wrong, and why the future of intensive care may depend just as much on what happens after ICU discharge as what happens inside the ICU. Welcome to This Week in Pulmonary and Critical Care Medicine, your weekly clinical intelligence briefing designed for busy pulmonologists, intensivists, fellows, and advanced practice providers. I'm Dr. Aladdin Sagar. Every week we go beyond the abstract to understand not only what a study found, but whether it should change the way we practice. Let's get started. One of the biggest dilemmas we face in acute pulmonary medicine isn't how to treat a pulmonary embolism, it's deciding who actually needs the CT scan to diagnose one. Nowhere is that dilemma more challenging than in patients with active cancer. Picture the patient we all see regularly, a 65-year-old woman undergoing chemotherapy for metastatic breast cancer presents with new shortness of breath. Her heart rate is mildly elevated. Her D-dimer comes back positive, which, frankly, isn't surprising. At that point, most of us stop thinking about clinical prediction rules and simply order a CT pulmonary angiogram. And for years, that has largely been supported by the lack of evidence rather than by strong evidence. The concern has always been that cancer changes the equation. D-dimer levels are frequently elevated, the baseline risk of venous thromboembolism is much higher, and the consequences of missing a pulmonary embolism can be devastating. So the safest approach seemed to be scanning everyone. But this week, the HYDRA trial, published in JAMA, asks an important question. Have we been performing more CT pulmonary angiograms than necessary? The investigators enrolled nearly 700 patients with active cancer who presented with suspected pulmonary embolism across 21 hospitals in 6 European countries. Patients were randomized to one of 2 diagnostic strategies. In one group, every patient underwent CT pulmonary angiography. In the other, clinicians used the YEARS algorithm, combining 3 clinical criteria with a probability-adjusted D-dimer threshold to determine whether imaging was actually needed. What's important here is that this wasn't another validation study asking whether the YEARS algorithm predicts pulmonary embolism. We've known for several years that it performs well in the general population. The uncertainty has always been whether that performance holds up in patients with cancer, where D-dimer loses specificity and clinicians are understandably reluctant to rely on clinical decision rules. The results were reassuring. Among patients in whom pulmonary embolism was excluded, the diagnostic failure rate at 90 days was just 1.8% in the YEARS group, compared with 5.5% in the group managed with routine CT pulmonary angiography. Now, I want to be careful with that comparison. The trial was designed as a non-inferiority study, not a superiority trial, so we shouldn't conclude that YEARS is somehow better than CT. But we can conclude something equally important. It was just as safe in this population. To me, though, the number that matters most isn't 1.8%. It's 22%. Nearly 1 in every 5 patients assigned to the YEARS strategy never underwent CT pulmonary angiography at all. Think about what that actually means. That's fewer patients receiving iodinated contrast, less radiation exposure, shorter emergency department stays, lower healthcare costs, and perhaps most importantly, fewer incidental findings that send patients down the rabbit hole of additional testing without improving outcomes. Sometimes we focus so much on avoiding misdiagnoses that we forget unnecessary testing carries its own risks. One aspect of this trial that I particularly appreciated is how pragmatic it was. This wasn't performed in a single academic referral center with highly selected patients. The investigators recruited patients from 21 hospitals in 6 different countries, and they enrolled individuals with active cancer who looked very much like the patients we see every week. That makes these findings much easier to apply to routine clinical practice. The physiology also makes sense. The years algorithm doesn't rely on D-dimer alone. Instead, it incorporates pre-test probability using 3 simple clinical questions before interpreting the D-dimer threshold. That's an important distinction because the problem in oncology isn't that D-dimer stops working, it's that D-dimer becomes less specific. By integrating clinical assessment first, the algorithm compensates for much of that limitation. Now, before we start rewriting every emergency department protocol, there are a few caveats worth remembering. These were stable patients. The study excluded patients who were hemodynamically unstable or had contraindications to CT pulmonary angiography. So if your patient is hypotensive, profoundly hypoxemic, or you're worried about a massive pulmonary embolism, this trial doesn't change anything. Clinical judgment still comes first. There's another point that's easy to overlook. Even with the years strategy, most patients still underwent CT imaging. Only about 22% avoided CTPA. So this isn't an imaging elimination strategy. It's an imaging optimization strategy. That's a subtle but important distinction. The goal isn't to do fewer CT scans at all costs. The goal is to reserve CT for the patients who are most likely to benefit from it. I also think this study highlights a broader lesson that extends beyond pulmonary embolism. Medicine has a tendency to exempt high-risk populations from clinical decision rules. Sometimes that's appropriate because the evidence truly isn't there. But other times, we simply assume that because patients are higher risk, established diagnostic strategies no longer apply. The HYDRA trial reminds us that assumptions need to be tested. In this case, the assumption that every patient with active cancer requires immediate CT pulmonary angiography simply wasn't supported by the data. So will this change my practice? I think it will. For stable patients with active cancer and suspected pulmonary embolism, I feel much more comfortable incorporating the years algorithm into my diagnostic approach rather than reflexively ordering CT pulmonary angiography for everyone. It doesn't replace clinical judgment, but it gives us high-quality randomized evidence that thoughtful risk stratification remains safe, even in one of the most challenging patient populations we encounter. And perhaps that's the biggest lesson from this study. High-risk patients don't necessarily need more testing. They need better decision-making. Let's switch gears from emergency medicine to the bronchoscopy suite. Here's a question that many of us probably don't think twice about anymore. You're about to biopsy a friable endobronchial tumor. Before taking the first bite, do you instill a few milliliters of diluted adrenaline? Maybe some ice-cold saline? If you do, you're certainly not alone. The logic seems almost self-evident. If these agents help stop bleeding after it occurs, why not use them before the biopsy to prevent bleeding altogether? It's a practice that's found its way into guidelines, expert opinion, and countless bronchoscopy units around the world. Yet, when you stop and ask yourself, what randomized evidence actually supports this, the answer becomes much less clear. That's exactly why I found the PROTECT study so interesting. Published this month in Chest, this multi-center randomized trial tackled a question that many of us assumed had already been answered. Does prophylactic hemostatic therapy actually reduce bleeding during endobronchial biopsy? The investigators randomized 462 patients undergoing endobronchial biopsy into 3 groups. One group received diluted adrenaline before biopsy, another received 4 degrees Celsius ice-cold saline, and the third received plain saline as a placebo. The primary outcome wasn't catastrophic bleeding, which fortunately is uncommon, but standardized assessments of biopsy-related bleeding severity and procedural visualization. And the results were remarkably straightforward. Neither prophylactic adrenaline nor prophylactic ice-cold saline significantly improved bleeding compared with placebo. Let me say that again because it runs counter to what many of us have believed for years. Giving a hemostatic agent before the biopsy did not reduce clinically meaningful bleeding during the procedure. That's an important negative trial. Negative studies often receive less attention than positive ones, but in procedural medicine, they're frequently the ones that simplify practice. Now, there was one finding that immediately caught my attention. In patients younger than 65 years, the investigators observed a modest reduction in bleeding with prophylactic ice-cold saline compared with placebo, with a relative risk of 0.90. On the surface, that sounds intriguing, but before we all start changing our protocols for younger patients, it's worth remembering that this was a subgroup analysis. The primary endpoint of the trial was negative, and subgroup findings should almost always be viewed as hypothesis-generating unless replicated. One thing I appreciated about this study is that it addresses a very common cognitive trap in procedural medicine. We often assume that because a treatment works therapeutically, it should also work prophylactically. But biology doesn't always cooperate. Take adrenaline, for example. When active bleeding occurs, vasoconstriction helps reduce blood flow, improves visualization, and buys us time to regain control of the airway. That's a completely different physiologic situation than instilling adrenaline onto intact mucosa before any vessel has been disrupted. The same applies to ice-cold saline. Cooling may promote vasoconstriction once bleeding has started, but that doesn't necessarily mean preemptive cooling prevents vascular injury when the biopsy forceps take their first bite. The PROTECT trial reminds us that plausible physiology is not the same as proven clinical benefit. The study also has several strengths. It was conducted across multiple hospitals rather than a single expert center, enrolled more than 450 patients, used randomized allocation with a placebo control, and evaluated outcomes that matter to bronchoscopists performing procedures in the real world. Another reassuring finding was safety. Neither prophylactic strategy increased biopsy-related complications or major adverse events. So while these interventions may not help, they also didn't appear to cause harm in this study. That said, there are important limitations. The bronchoscopists performing the procedure were not blinded because they had to administer the assigned intervention. While bleeding was assessed using standardized scales, complete operator blinding simply wasn't feasible. More importantly, this study focused specifically on routine endobronchial biopsy. It doesn't answer whether prophylactic hemostatic therapy has a role during higher risk procedures such as transbronchial lung biopsy, cryobiopsy, or biopsies in patients with unusual bleeding risk. Those remain separate clinical questions. And that's where I think the real message lies. This trial isn't telling us to throw away our adrenaline or stop keeping ice-cold saline on the bronchoscopy cart. Quite the opposite. These agents remain essential rescue therapies when bleeding actually occurs. What this study challenges is the routine habit of using them prophylactically in every patient simply because we've always done it that way. Will this change my own practice? Yes. I don't see convincing evidence to continue routine prophylactic instillation before standard endobronchial biopsy. I'll continue to have adrenaline and cold saline immediately available, but I'll reserve them for the situation they were originally designed for, controlling bleeding once it happens, not trying to prevent a problem that, according to this trial, they don't meaningfully prevent in the first place. And I think that's the broader lesson from the PROTECT study. As proceduralists, we're constantly tempted to add one more step just in case. One extra medication, one extra maneuver, one extra precaution. Sometimes those additions improve outcomes, but sometimes they're simply traditions that have survived longer than the evidence supporting them. The best proceduralists aren't the ones who do the most. They're the ones who know which steps truly matter and which ones can safely be left out. Now I'd like to end today's episode with something a little different. Instead of discussing another randomized trial, let's step back and think about one of the biggest challenges in critical care today. For decades, we've measured our success by getting patients out of the ICU alive, and that's absolutely appropriate. Mortality has fallen dramatically over the last 2 decades. We ventilate patients more safely. We recognize sepsis earlier. We use lighter sedation, lung protective ventilation, and structured liberation from mechanical ventilation. Modern critical care has become remarkably good at keeping people alive. But here's the uncomfortable question. What happens after they survive? Because for many patients, survival isn't the finish line. It's the beginning of an entirely new illness. A state-of-the-art review published in Thorax tackles exactly this issue, exploring where we stand today in helping patients recover after critical illness, and perhaps more importantly, why so many continue to struggle months or even years after leaving the ICU. Most of us are familiar with the term post-intensive care syndrome, or PICS, but it's worth remembering that PICS isn't one disease. It's really a collection of long-term impairments affecting physical function, cognition, and mental health. The review reminds us that these problems are not rare complications. They're common consequences of surviving critical illness. Patients frequently report persistent muscle weakness, shortness of breath, insomnia, memory problems, impaired concentration, anxiety, depression, and post-traumatic stress symptoms that can last for years after hospital discharge. One statistic in particular stopped me. About 26% of ICU survivors have cognitive performance 1 year after discharge comparable to patients with Alzheimer's disease. Think about that for a moment. Not delirium in the ICU, not transient confusion, persistent cognitive dysfunction 1 year later. As pulmonologists and intensivists, we often celebrate when a patient is successfully extubated and discharged from the ICU. We should celebrate that milestone. But this review reminds us that extubation is not the end of recovery. It's simply the point where recovery changes location. The article then walks through what we currently know about improving long-term outcomes, and one message becomes very clear. There isn't one intervention that fixes PICS. Recovery begins on the very first day in the ICU. One of the strongest concepts discussed is the ABCDEF bundle. We often think of it as an ICU quality initiative, but it's really a recovery program disguised as an ICU bundle. Every component, optimizing analgesia, minimizing sedation, preventing delirium, encouraging spontaneous breathing, promoting early mobility, and engaging families, is designed to reduce the burden of long-term disability, not just improve what happens during the ICU stay. Higher adherence has consistently been associated with less delirium, shorter ventilation, fewer restraints, and lower ICU readmission rates. That naturally leads to one of the most debated topics in critical care, early mobilization. For years, we've believed that getting patients moving earlier should translate into better long-term outcomes. And in many ways, that still makes intuitive sense. Earlier studies demonstrated improved functional independence, while more recent trials have produced more mixed results. The review does an excellent job explaining why these studies appear to conflict. It's probably not that early mobilization doesn't work. Rather, early mobilization isn't a single intervention. Timing, intensity, patient selection, staffing, sedation practices, and the definition of mobility vary enormously between studies. In other words, we've been asking whether early mobilization works, when perhaps we should have been asking which patients benefit, when they benefit, and how much therapy is enough. Another intervention that I think deserves more attention is the ICU diary. At first glance, it sounds surprisingly simple. Family members and staff document what happened during the ICU stay using everyday language, creating a narrative that patients can later read to fill in the memory gaps created by sedation, delirium, and critical illness. It almost sounds too simple to matter. Yet multiple studies suggest ICU diaries are associated with lower rates of anxiety, depression, and post-traumatic stress disorder for both patients and their families. That's a remarkable finding because it reminds us that healing after critical illness isn't purely physical. Helping patients reconstruct the story of what happened to them may be just as important as rebuilding muscle strength. The review also highlights something we don't talk about enough: the transition out of the ICU. The authors argue that these transitions may represent one of the weakest links in recovery. Better discharge planning, standardized handoffs, medication reconciliation, individualized discharge information, and coordinated rehabilitation programs all appear capable of improving long-term outcomes. In fact, approximately 1/3 of adverse events occurring after ICU transfer are considered preventable. That's an astonishing number when you think about it. Perhaps the most important lesson from this review isn't about any single intervention. It's about changing our definition of success. For years, we've asked, did the patient survive? Maybe the better question is, what kind of life did the patient return to? If there's one teaching pearl I'd leave you with today, it's this: the ICU stay is only one chapter in a patient's recovery story. The decisions we make on day one, how deeply we sedate, how quickly we mobilize, how we involve families, and how carefully we plan the transition out of the ICU, can shape a patient's quality of life months or even years later. And perhaps that's the future of critical care. Not simply helping more patients survive, helping more survivors truly recover. As we wrap up this week's episode, I think there's an interesting thread connecting all three papers, even though they seem to address completely different areas of pulmonary and critical care. The first study challenged the assumption that every patient with active cancer and suspected pulmonary embolism needs an immediate CT pulmonary angiogram. The HYDRA trial reminded us that careful clinical reasoning, supported by a validated diagnostic strategy, can safely reduce unnecessary imaging without compromising patient outcomes. The second study challenged a procedural habit that many of us have practiced for years. The PROTECT trial showed that routinely instilling adrenaline or ice-cold saline before an endobronchial biopsy doesn't meaningfully reduce bleeding. Sometimes the best evidence doesn't tell us to do something new. It tells us we can stop doing something old. And finally, the Thorax review encouraged us to rethink what success in critical care really means. Saving a patient's life is an extraordinary achievement, but it's no longer the only outcome that matters. As our patients survive critical illness more often, our focus must expand beyond ICU discharge to include physical recovery, cognitive function, emotional well-being, and quality of life months after they leave our care. If there's one common message from all three papers, it's this: good medicine isn't about doing more, it's about doing what matters most. Ordering the right test instead of every test, performing the interventions that are supported by evidence instead of tradition, and remembering that every decision we make today can influence how our patients are living months or even years from now. Those are exactly the kinds of studies I enjoy sharing with you each week, not because they're guaranteed to change guidelines overnight, but because they change the way we think. And ultimately, that's where meaningful improvements in patient care begin. Thank you for spending part of your week with me. If you found today's discussion valuable, I'd appreciate it if you shared the episode with a colleague, a fellow, or someone in your ICU or pulmonary division. These conversations are always better when more clinicians are part of them. If you're new to the channel, consider subscribing so you don't miss next week's review of the latest and most clinically relevant literature in pulmonary and critical care medicine. Until next time, stay curious, keep questioning your assumptions, and as always, thank you for everything you do for your patients. I'm Dr. Aladdin Sagar, and this has been This Week in Pulmonary and Critical Care Medicine. I'll see you next week.